Thank you very much, Christian. I don't know where we are now. We are late, I know. So these will be the topics. These topics will I speak about. I used to start my lectures with these pictures, and now take a deep breath, let oxygen in until the animation is over, and we go further for the next slide, because we know the main target of our cardiorespiratory system is to keep the balance between oxygen delivery and oxygen consumption. And our system focuses on cardiac output as the main target parameter to restore and preserve cardiac output. Cardiac output is determined by heart rate and stroke volume, as we know. And since the experiment of Starling, we know that preload and afterload are the main determinants of cardiac output if the contractility and heart rate is okay. So if we decrease the preload or increase afterload, the systemic vascular resistance, the cardiac output will decrease, and the opposite happens if we give fluids or give vasodilators, and we increase preload or decrease afterload. But what happens if the patient is on this part of the curve, because if the afterload decreases extremely, and the patient will reach vasoplegia, we will see a hypertensive patient with impaired mental state, oliguria, and elevated arterial lactate levels. So we have to give something because these signs indicate circulatory and metabolic or cellular abnormalities. So this patient needs vasopressors to reverse vasoplegia and restore the balance between oxygen consumption and delivery. I won't go deep into the pharmacodynamics of the vasopressors, but some key points I need to share with you. All vasopressors increase arterial and venous tone also. They increase afterload, and they increase preload also by redistributing the unstressed hemodynamically inactive blood volume from the venous part of the circulation. So this is what they do. But unfortunately, all of them has main side effects. Cardiac arrhythmias and ischemic events can occur if we give vasopressors. So our first question is, which vasopressor should we choose as first-line treatment? The Surviving Sepsis Campaign guideline gives a recommendation, and it's a strong recommendation, that we have to use norepinephrine with a target map of 65 millimeters of mercury. So I think question one is answered, problem solved. So let's go further. But wait, why should we target 65 millimeters of mercury? Because it has data from a clinical trial. It was found in this trial that 65 millimeters of mercury map is predictive for survival. But look at in physiology. We know that we have an artery regulation zone and circulation. With no prior hypertension, we see this kind of curve. But in patients with prior hypertension, the autoregulation zone shifts rightward and upward, so these patients will need higher MAP targets, as indicated in this paper, where patients were resuscitated for the same MAP target. And what happened? Patients with hypertension had more and significantly more kidney injury than patients who had no hypertension. So we have to individualize MAP targets, and we need this approach to treat our patient appropriately. The second question is the vasopressin dilemma. What is the background of using vasopressin? We know that vasopressin acts on three types of receptors, and we will choose the V1A receptor because vasopressin will increase blood pressure by vasoconstriction on this type of receptor. And interestingly, in sepsis and shock, vasopressin constricts the glomerular efferent arterioles, and it leads to a higher GFR and a better urine output, theoretically. And we know that no evidence of severe splanchnic or mesenteric ischemia occur if we use vasopressin. It was a quite good study, and it gives the background for vasopressin substitution, because they found that in septic shock, the circulating endogenous vasopressin levels were extremely low in this patient compared to in cardiogenic shock or in patients with normal circulation. And if they gave vasopressin, they reached good MAP targets. And this hemodynamic improvement was significant. And if we look at this data, we will see that the background vasopressor requirements decreased when they added vasopressin to these patients. This was the VAST trial, and they found that if vasopressin was the first line vasopressor, there were no significant decrease in mortality, only in patients with less severe septic shock. But how we know that a patient is in a less severe state, I don't know. But it's obvious that no more adverse events were observed when patients got vasopressin. And I think it's a important message. The initial hypothesis in this study was whether vasopressin was superior to norepinephrine, and they found that low-dose vasopressin did not reduce mortality. But if we choose these words, then we can say vasopressin was not inferior to norepinephrine. So why don't we choose it? This was a post-hoc analysis of the VAST trial, and they found that vasopressin may reduce progression to renal failure and mortality in patients at risk of kidney injury who have septic shock. And the Vanish trial strengthened these findings, and they found that there was less use of renal replacement therapy in the vasopressin group than in the norepinephrine group. And the early use of vasopressin, unfortunately, did not improve the number of kidney failure-free days. And this is a quite new meta-analysis on the use of vasopressin as first-line vasopressor agent. They found no difference in mortality, no difference in ICU mortality, no difference in the secondary outcomes, length of hospital stay, ICU stay, and so on. No difference in the urine output, and fortunately, no difference in serious adverse events, but they found a sign that the odds of renal replacement therapy requirement were significantly lower in the vasopressin group. So maybe vasopressin can be considered as first-line agent in patients with high risk of renal replacement therapy requirements. But what tells us the Surviving Sepsis Campaign guideline? It tells that we have to add vasopressin as second-line agent to norepinephrine if norepinephrine requirements exceeds this dose. In our practice, we use vasopressin if norepinephrine dose exceeds 40 microgram per minute. Just some words about vasopressin analogs, because someone uses terlipressin in Hungary, but I don't know whether anyone uses celepressin. These studies were addressed to find the place of these agents in vasopressor treatment, but both trials were stopped for futility and due to the serious adverse events. So the guideline says it suggests against using terlipressin in septic shock. However, it's a weak recommendation and low quality of evidence. A novel agent, angiotensin II, is based on the pathophysiology that renin cleaves angiotensin again to angiotensin I, then it is converted to angiotensin II, and it acts on its type 1 receptor and results in vasoconstriction. But what happens during septic shock? Due to the endothelial injury, the activity of the convertizing enzyme decreases, plasma renin concentration increases, and moreover, the type 1 receptor is downregulated, and this is DPP3 enzyme that enhances angiotensin II breakdown. So it has pathophysiological rationale to substitute angiotensin II these patients, and this is a novel research. The inhibition of this enzyme by a specific antibody to elevate the angiotensin II levels by inhibiting this enzyme. So this was a trial that led to the introduction of angiotensin II into clinical practice. These patients were on high dose for norepinephrine for 6 to 48 hours. The primary endpoint was response to the investigational drug. It was a placebo-controlled trial, and they found that angiotensin II had a significantly more increase in patients as compared to patients who received placebo. Moreover, the background vasopressor requirement decreased if they were given angiotensin II. And this post-hoc analysis were addressed to find which patients benefit the most from angiotensin II administration, and it seems that patients with relative angiotensin II deficiency, increased serum renin concentrations, or acute kidney injury requiring RRT, these patients are for angiotensin II, but there is no clear evidence now, so angiotensin II is just for second line. Epinephrine is our old friend. I don't tell too much about it because it is recommended only if norepinephrine is not available or in impaired cardiac function. But in this scenario, we choose dobutamine or levosimendan. Marco will talk about it in the next lecture. So let's go further. And the guideline is suggesting only as third-line agent. It's a quite interesting thing that methylene blue has antivasodilator effect, and in this interesting experiment from a member of SEPS East, Mikhail Kirov from Russia, it was found that if they give methylene blue to their patients as compared to saline infusion, there was a significant increase in MAP. And it was strengthened by this narrative review and systematic review. However, they found significant hemodynamic response and a vasopressor sparing effect. The blue discoloration of the skin is really bizarre. I'm honest, this is a methylene blue intoxicated patient in our ICU, but it's similar when we gave methylene blue. This is a quite new paper from Arias Ortiz and Jean-Louis Vincent, and they told is giving methylene blue is a matter of debate, and its role in the treatment of septic shock is unclear. So question 1 is answered. We have a strong recommendation, but I think some questions arise. The second question, when should we initiate vasopressor treatment? And as we know that every hour in shock increases mortality and the risk of organ failure. So we have to give vasopressors as early as possible via a peripheral vein catheter, and we can reach a shorter time to commence antimicrobials and vasopressor treatment. So the guideline says consider initiating vasopressors peripherally. However, we have to put in a central venous line. So the earlier, the better. The third question, should we apply combined vasopressor therapy early? In this experiment, the principal exposure was the last norepinephrine dose when adding a second vasopressor. These were the cutoff parameters, and the primary outcome was mortality. they found a lower 28-day mortality in the early group, and they found a cutoff dose of 0.18 micrograms per kilogram per minute, and it's lower than recommended. So further RCTs are needed to answer these questions, I think so. So we answered the third question with remarks, apparently more beneficial, but we don't know where we are. And the final question, how should we wean our patients from vasopressors? Because we know that the cumulative dose and the duration of vasopressor treatment is associated with increased mortality, so we have to wean as soon as possible our patients. Which vasopressor should we discontinue first? This was retrospective analysis, and they found if vasopressin was discontinued first, the mortality arose. So, the hypertension, the risk of hypertension arose, and that was the opposite. If they discontinued norepinephrine, the rate of shock reversal was significantly higher. So maybe we have to wean our patient first from norepinephrine and not from vasopressin. If we look at the data and we choose only a subgroup of septic shock patients, we see that more severely ill patients were in the vasopressin group, and it was a significantly higher incidence of hypertension, but shorter ICU and in-hospital days if we weaned from vasopressin these patients first, and there was no impact on mortality and other outcomes. A quite opposite result was in this paper. However, several limitations arise in the post hoc analysis of this study, and the mortality in the vasopressin group was significantly higher. So the debate is being continued. There are no optimal order, or it is unclear. There are no recommendations. So what should we choose? The patient's clinical condition, that's what we do every day. We examine the patients, we examine mental state, laboratory results, radiological findings. These are important, but I think not enough. We can choose hemodynamic parameters. That's the part of the routine standard care, and it's a novel thing, the dynamic arterial elastance, that defines the changes in the arterial pulse pressure caused by the changes in the left ventricular stroke volume, and it's a good predictor of hypertension. It's a quite fresh paper from this year based on 5 studies, and they found that a cutoff of 0.89 predicts no reduction in the mean arterial pressure during the weaning of vasopressor support. And it's interesting, I don't know whether anyone tried it, an oral epinephrine as adjuvant treatment during the weaning. It's interesting, but I don't know where we are now. So how should we wean our patients from vasopressors? In the absence of recommendations, answer remains unclear, and further research needed, I think so. The take-home message, use appropriately the vasopressors, initiate as soon as possible, apply appropriate dose, use combination, wean as soon as possible, and the recommended first-line vasopressor is norepinephrine, but some concerns arise. Thank you very much.